Thank you for joining today. I'll be talking about how to maximize interactions with dermatopathology. And for this talk, I have no relevant conflicts of interest. So the focus of today's talk is really on clinical pathologic correlation, or CPC, which is, from my perspective, the key to obtaining specific diagnoses for our patients. And CPC is fundamentally the integration of the clinical manifestations of a disease process with the histologic findings that are seen by dermatopathologists, with the purpose being obtaining meaningful biopsy results that can be put in the right clinical context to guide the patient management plans to provide the best care for our patients. And fundamentally, dermatologists make diagnoses, and the skin biopsy is a fundamental portion of that clinical diagnostic process, but it is not the end step. It really needs to be integrated in to the clinical diagnosis in order to formulate a management plan to guide the care of our patients. And one important thing to remember here is that dermatopathology is not magic. It's not just a simple lab test where you get a definitive result necessarily at the end of the biopsy process. It really has to be integrated into the clinical context in order to make a clinical diagnosis. The skin biopsy provides a histologic diagnosis, but again, it has to be put into that important clinical context. So when we're seeing patients in clinic, we start with identifying the features that trigger the thought process in our mind of the need for a biopsy. So we're looking at patient demographics, the morphology of the skin lesion that we're looking at, and formulating a differential diagnosis. And we think about when to perform a biopsy, what type of biopsy to perform, and how to submit it. And the end result of the histologic diagnosis helps give us essential information for rendering the care of our patient. But after that step, after we get the biopsy result back, we still need to translate that into a clinical diagnosis using clinical pathologic correlation to then take that information and formulate a management plan for the care of our patient. So how can we get, as clinicians, the most information from our biopsy and achieve that clinical pathologic correlation? And for that, there's some just general principles for when to perform a biopsy. And it's essential to really do this when you have a clear purpose, where you understand what the work that you want your biopsy to do for you in the clinic. And it's very helpful to think about the type of information that you might obtain from the biopsy so that you can really achieve a specific diagnosis that allows you to get the information you're looking for your patient. And the first part of that step is to really communicate clearly to the dermatopathologist to be able to get the information out that you're looking for. Because as we all know, garbage in, garbage out. If you don't give clear information, you won't get clear information out. And fundamentally, the type of biopsy that we perform in the clinic is guided by what we're seeing in the patient in front of us, the clinical morphology and the formulated differential diagnosis that we have in mind. And one thing that's often overlooked is that the type of biopsy that you perform in clinic actually communicates meaningful information about your thought process in the clinic, as certain morphologies and differential diagnoses really require particular biopsy approaches. And we really hone this over the course of our practice, that the type of expected histopathology that we're looking for will really impact the type of biopsy that we take in the clinic. So here's a list of the types of biopsies and the types of lesions that they're really intended to focus on. And the different lesion types are best sampled using different techniques. So for example, a shave or tangential biopsy is really well suited for macules and patches, where you're looking for sampling the epidermis or the superficial dermis, whereas a punch biopsy is really ideal for a small lesion or a papule, where you can get both epidermis, dermis, and maybe a superficial portion of the subcutis. Incisional biopsies are for larger lesions where you need really a full thickness and adequate sampling of the subcutis. And excisional biopsies are for when there's a variegated tumor or whether there's a high impact of a malignant diagnosis and there's of utmost importance to sample the lesion in its entirety. And a good example of how impactful this can be is that, again, the type of biopsy that you perform communicates significantly what you're thinking to the dermatopathologist who's interpreting that biopsy. So we'll start with sweet syndrome. And if you're confronted with a patient with an indurated plaque or nodule seen here on the cheek, you're thinking about or imagining a dermal process, something that's going to require a punch biopsy. And in this case, if you were to perform a shave biopsy, it wouldn't be possible to identify the types of changes that you need to on the biopsy reliably. And it might limit the type of diagnostic information that you could get back from that sample. However, if you perform a punch biopsy, you can see this diffuse to nodular infiltrative inflammatory cells here in the mid to deep dermis that really is required to help give a definitive diagnosis of sweep syndrome and give you that close clinical pathologic correlation that we're intending to get here. And so it's important to start that process by selecting the right biopsy type and then also completing the requisition form, which is really the first chance that the clinician has to articulate their thought process to the dermatopathologist and really guides the diagnostic workflow for dermatopathology. In the first example here, just listing rule out lesion is not really adequate to really guide the thought process for the interpreting dermatopathologist. However, providing biopsy site, the relevant clinical information, and a brief differential will ensure that your dermatopathologist can give you the type of information back that you're looking for. And here, when you identify that you're looking for basal cell carcinoma versus fibrous papule, they'll likely get deeper levels if they don't see a basal cell, really identifying the issue at hand and helping the clinician get the most from their biopsy. Other important details that are very important for the workflows for biopsy submission are to include the pertinent patient information and again, some of that key clinical information so that you can list your thought process and really begin the conversation from dermatology to dermatopathology. So here are just some quick pearls as we wrap up. If it's worth a biopsy, it's worth a photo. Limiting one specimen per bottle and ensuring that that bottle lid is actually closed before it's sent off to your dermatopathologist, and having a biopsy tracking system so that you can communicate your biopsy results back to your patients in order to complete the diagnostic loop and integrate those results into your clinical management plans. So finally, I just want to emphasize that dermatologists are really making diagnoses and making these clinical diagnoses using clinical pathologic correlation. And that when you start thinking that a biopsy is needed, the type of biopsy that you select really communicates a great deal to your dermatopathologist about what your differential diagnosis is, what is the type of information that you're looking to get out of your biopsy, and it also will include the information that you list on your path requisition form that will help guide the thought process. And again, just advising you to have a systematic approach that enables clinicians to really get the most out of their biopsy and obtain clinical pathologic correlation. And please contact your dermatopathologist if you have questions or if you really want to communicate with your dermatopathologist further, they'll be happy to field those questions. Here are some references and acknowledgements, and I appreciate your attention. Thank you.